Hypertension is defined by various groups. There is actually an article called Harmonization of the American College of Cardiology, American Heart Association, and the European Society of Cardiology, and European Society of Hypertension guidelines. So they are able to compare and reflect and recommend what are the common grounds for managing hypertension and even hypertensive crisis. So the latest guidelines came from the European Society of Hypertension, last just published this year. So this is actually the slide which tells us of how we define hypertension. So according to the American College of Cardiology, so normal blood pressure should be less than 120 and less than 80 diastolic. So when you say systolic blood pressure, it's actually the numerator, and the diastolic blood pressure is the denominator. When you say systolic blood pressure, it's actually the pressure generated in the vascular system as the heart pumps, contracts. While the diastolic blood pressure is actually the pressure in the vascular system by which during the time when the heart relaxes. So if you have these blood pressure like less than 120 and less than 80, so that's normal blood pressure for you. However, in this day and age of sedentary lifestyle and uh, uh, fast food chains and GMOs, elevated blood pressure is already claimed to be 120 to 129 and less than over 80. So if you say that your blood pressure is 120, you don't say it's normal anymore. It's already elevated. Or if you say 125, it's not normal anymore. It's already elevated. So you need to do something about it so that you can halt or delay the progression or the occurrence of going into stage 1 hypertension. And stage 1 hypertension is actually if you have systolic blood pressure of 130 to 139 or a diastolic blood pressure of 80 to 89. So if you say that your blood pressure is 130 over 60, that's stage 1 hypertension. Or say that your blood pressure is 110 over 90, that's actually already stage 2 hypertension because over 90 is stage 2 hypertension. Hypertension stage 2 is the systolic blood pressure is more than 1 or equal to 140, or the diastolic pressure is less or more than or equal to 90. Blood pressure is 150 over 70, that's stage 2, or 130 over 90, that's stage 2 hypertension. The European Society of Cardiology and European Society of Hypertension has a different level range of values in terms of defining hypertension in the European continent. So we have the same levels for optimal, but grade 1 hypertension starts at 140, and then it's up to grade 3 of more than 1 or equal to 180. And then we have also defined isolated systolic hypertension as more than 140 and a diastolic pressure of less than 90. So what is the global burden of hypertension? This is according to the report of the World Health Organization last March 2023. That report tells us that there's an estimated 1.28 billion adults aged 30 to 79 years worldwide have hypertension. And most of that number lives in low and middle income countries, including the Philippines. So there's actually also an estimated 46% of adults with hypertension who are actually unaware that they have this condition. So they are asymptomatic. They don't know or they don't feel that they have the hypertension just because they're not checking their blood pressure. So this time, whether you are in your 20s, in your 30s, you should be checking your blood pressure. We should be checking our blood pressure so that we will be aware of what type of management we are going to use if we will know the values of our blood pressure. But less than half of the adults, 42% with hypertension, are diagnosed and treated, and approximately 1 in 5 adults, approximately 21% with hypertension, have it under control. So there's very few of them who reach these goals. Goals are very important so that we can prevent the occurrence of major adverse cardiovascular events and at the same time target organ damage. Hypertension likewise is a major cause of premature death worldwide. How about in the Philippines? The Philippine burden of hypertension. Amongst the hospital-based population, hypertension remains the highest amongst the cardiovascular diseases. followed by stroke, and then ischemic or coronary artery disease, and then heart failure. In this particular study done by Dr. Jorge Cesar, it was published last 2020, conventional thresholds tell us that there is actually a 69% well-controlled clinic blood pressure. That was when the time when blood pressure guidelines is before 2017. However, 2017 guidelines told us that there's a stricter BP control. And when that uh, guideline in the ATC came out, there's only 43% have well-controlled clinic blood pressure. This again, the study by Dr. Mercado Asis, which was published just this year. So the impact, so the Philippine burden of hypertension tells us that because of the uncontrolled hypertension, productivity at home showed the following. So there's 6 days of household suspended, 11 days of reduced household work, and 5 days affected social activity. The productivity loss of premature mortality accounts for 17% of the total economic burden in 2020 and will increase to 20% by 2050. Economic cost actually rises as the years go by. So that's 1 billion in 2020 and 1.9 billion by 2050. Before we delve deeper into the meat or gist of this talk, we are going to review what is blood pressure. So we're going to have a hemodynamics review of the BP concept. So we have to know, we have to realize that blood pressure is an equation. So it's actually blood pressure is equals to cardiac output times systemic vascular resistance. So if you have, so these are the direct contributors or the direct factors which causes the increase or the decrease of the blood pressure. So if we say that we have a decreasing cardiac output, there should also be decreasing blood pressure unless the systemic vascular resistance increases to cancel out that effect. And for example, if you have decreased systemic vascular resistance, likewise, and the cardiac output remains constant, there should be a decreasing blood pressure. So if, because cardiac output is actually a function of the blood pressure times systemic vascular resistance, cardiac output is also put in an equation. Cardiac output is equal to stroke volume times heart rate. So if we decrease heart rate, for example, if you lower down the heart and stroke volume remains constant, then you have decreasing cardiac output. However, if you also decrease stroke volume, which is the volume of blood being ejected from the heart during each beat, also decrease cardiac output. So these stroke volume and heart rate are directly proportional to the cardiac output. And we have systemic vascular resistance, which is AT times mean arterial pressure minus central venous pressure and divided by the cardiac output. So this is actually the way or the intensity by which our vascular system constricts or dilates. So if you have constricted a vascular system, likewise, that will increase the pressure inside the vasculature, thereby giving rise to increased blood pressure. So that is the BP concept or our hemodynamics.
world moves in real time. So should our healthcare technology. With information needed, decisions to make, and experience to share, every second counts. Live integrated teleultrasound enables real-time communication, remote collaboration, confidence, knowledge, and learning. The first ever integrated teleultrasound collaborative platform. Philips Lumify. Integrated teleultrasound powered by React's collaborative platform. Innovation and you, Philips.
So if you have increase in cardiac output, if you have increase in heart rate, so likewise, your blood pressure will be increased. And if it gets increased over time, if you have an elevated blood pressure at more than 2 times the monitoring in a week, so you are already coined as hypertension. Or if you have the capability to submit yourself to a 24-hour BP monitoring, then the average blood pressure during the 24 hours, and even the blood pressure dip during nighttime and while we were asleep can actually detect whether we are hypertensive or not. And once we are hypertensive, we need to go into this particular management by which we need that can actually lower down the blood pressure. It can be non-pharmacologic, like lifestyle changes. However, again, as I said, this day and age of sedentary lifestyle and fast food uh, and the food that we eat, there's actually actually a very challenging task control BP just by lifestyle modification. Sometimes we need to be placed on antihypertensive medicines to control our blood pressure more adequately and to reach goals at a faster pace. Because the higher or the longer time that you are hypertensive, the more chances that you develop or reach the complications from the hypertension. In this particular slide, according to Braun textbook of cardiovascular diseases, tells us of the different drugs that can be used in hypertension management. So first, if you're pre-hypertensive, probably you can use an ARB, but hypertension in general, you can use your calcium channel blockers, your ACE receptor, receptor blockers, or your ACE inhibitors, and your diuretics. However, I want to highlight in this particular slide the use of beta blockers. Way back then, when I was still a med student, the beta blockers are still one of the first line drugs for hypertension. However, as the years went by, and with the revision of the different hypertensive guidelines, they took out the beta blocker as a first line drug. However, you can institute it in the management of hypertension if in the event that you have, say, for example, ischemic heart disease, or even have arrhythmias in the form of, say, atrial fibrillation. So you can place it at whatever timeline if you have these comorbid conditions to contend with. So I would also like to highlight the role of beta blockers in patients with a secondary use for secondary prevention of coronary events, like for example, if you already had a heart attack, or patients with heart failure. So we have the beta blockers which we can use for HFrEF, especially for heart failure with reduced ejection fraction. And also beta blockers can be used in pregnancy as a first line drug, especially in hypertensive crisis, in aortic aneurysm, especially those with complications like those with dissection and atrial fibrillation to control the ventricular rate. Then we go to one of the many dire complications of hypertension, which is hypertensive crisis, which can actually be lethal in the wherever you are in this in the community, whether you're at home or in the emergency room, or whether you are in the ICU or ward. Hypertensive crisis is defined as a systolic blood pressure of more than or equal to 180 or a diastolic pressure of 110 and above. So we define hypertensive crisis that uh, are as hypertensive urgency, with which tells us about elevated high blood pressure, elevated blood pressure without target organ damage, or those with patients with hypertensive emergency with target organ damage. When we say target organ damage, these are actually the dire effects of hypertension in our organs. For example, the heart. You go into have if you have hypertensive crisis with pulmonary edema or severe heart failure. If you have, say, for example, you have ischemic stroke or hemorrhagic stroke, uh, or even, for example, you have, say, retinal hemorrhages, or even like, say, PA, peripheral arterial occlusive disease. Those are actually our target organ damages. So these are the end organ or target organ damages. So first, neurologic, which can be the most common of which is cerebral infarction at 24.5%, seconded by hypertensive encephalopathy, and the third is intracerebral hemorrhage or subarachnoid hemorrhage. For cardiovascular diseases, I mentioned earlier pulmonary edema. For renal diseases, acute kidney injury or kidney failure. For liver, elevated liver enzymes in the form, for example, of the HELP syndrome, like hemolysis, elevated liver enzymes, and low platelets, ocular retinal hemorrhages, vascular eclampsia, and aortic dissection. So there are associations and causes by which hypertensive emergencies ensue. So the associations are as follows. So female sex highly associated with hypertensive emergencies, patients with high-grade obesity, patients with concomitant hypertensive or ischemic heart disease, patients with mental illness, or there's a high pill burden of BP meds with non-adherence. And then, what are the causes of hypertensive emergencies? Intoxication. So, for example, if you have been taking illicit drugs or even drugs that actually uppers that can cause hypertensive emergency, the most common cause of decompensated blood pressure is actually non or resistant hypertension. It's non-adherence to your hypertensive medications. Withdrawal syndrome, for example, if you've been taking this particular hypertensive drug, if you withdrew it immediately or outrightly, then you have rebound hypertension, you have drug-drug or drug-food interactions, spinal cord disorders, pheochromocytoma. Pregnancy can also be one of the leading causes of hypertensive emergencies and collagen and vascular diseases. So this particular slide tells us of the vicious cycle of hypertensive crisis. First, there is loss or failure of autoregulation. When we say autoregulation, is actually the negative feedback loop of our blood pressure control. So for example, if you lose that control, then blood pressure goes with increasing systemic vascular resistance and increasing cardiac output, which also leads to recurrent vasoconstriction. And these vasoconstrictions can lead into endothelial injury with activation of the renin and aldosterone system, and also giving rise to a prothrombotic state leading to ischemia and eventually destroys our organs, as mentioned earlier. So how do we treat hypertensive crisis, especially hypertensive emergency? So this is our BP target, or this is our general guidelines or treatment goal. In the first hour of hypertensive emergency treatment, we need to reduce mean arterial pressure by 25% while maintaining the diastolic blood pressure up to more than 100 mmHg. So in 2 to 4 hours or 2 to 6 hours, systemic blood pressure should be already reached at 160 mmHg, or the diastolic pressure should be between 100 and 100. And at 6 to 24 hours, we can maintain goals for blood pressure during the first 24 hours at the same 160 over 100, 160 over 100. If you get to notice, we don't really aggressively decrease diastolic blood pressure, especially in hypertensive emergency, because that is actually detrimental, especially to the coronary circulation. And then 24 to 48 hours, we can have outpatient BP goals according to 2017 ECC guidelines for the management of high blood pressure in adults. If you're, for example, you're not diabetic, you don't have CKD, your BP goals outpatient should be less than 140 and less than 90. While if you are hypertensive, if you are diabetic, and if you have chronic kidney disease, our goal for systolic and diastolic blood pressure should be less than 130 over. However, because there are exceptions to the rule, these are the exceptions to the general treatment goals for hypertensive emergency. That means we can actually decrease blood pressure at a faster rate as compared to that of the general treatment goals we discussed just a while ago. So these are the conditions. First, we should be reaching better blood pressure or a faster BP control. Patient is having aortic dissection. That means parang napupunik yung aorta of, say, some, like for example, aneurysm. And then acute stroke, ischemic and hemorrhagic. However, in ischemic stroke, you want to taper it down to our target mean arterial pressure. For hemorrhagic stroke, we want to reach goals at a faster pace so that our functional capacity of our patient may be better in 3 months' time. And also the exception, one of the exceptions is pregnancy-associated severe hypertension, pregnancy-induced hypertension in the form of preeclampsia and eclampsia, and hypertensive emergency in the pregnant patient. So how do we treat hypertensive emergency? So our choice of medications actually depend on these factors. First, it depends on affected target organ on the patient. Secondly, the PK/PD of the medications available. So when we say pharmacokinetics or PK, what are the drug, what the body does to the drug. And if we say pharmacodynamics, what the drug does to the body. And then hemodynamic, adverse effect and blood pressure variability profile of medication options. When we say blood pressure variability, it's actually the rise and dip of your blood pressure. If you get to compute that in an average or in a standard deviation, we should avoid 2 BP spikes into low blood pressure so that we don't actually adversely affect the autoregulation of our vascular system. So these are the preferable traits of medications used to treat hypertensive emergencies. First, it should be intravenous, administered intravenous. So it's very important because intravenous administration has a faster onset of action. At the same time, the patient may not be even capable to drink oral medicine or even sublingually because of some effect to the absorption. And then the ability to be titrated to the desired effect, allowing for a smooth reduction of blood pressure, have a short duration of activity so that you have fast on, fast off in your blood, and should have minimal adverse effect profile.